Welcome to our virtual open house. Thanks so much for joining us this evening. We are really excited to kick off this year's recruitment season and showcase our program. Tonight's agenda includes introductions of our panelists, a brief informational presentation about our program and what it's like being a resident in Iowa City. We will close with a question and answer session during which we will include both questions that were previously submitted to us and also questions that you send us tonight through the Q&A text box. And tonight's session is being recorded and will be posted on our website for you to view later on. So fun photo here of two of our previous residents and Dr. Yamada, who was one of our electrophysiologists flying his plane. So let's meet our panelists. I'll start. My name is Andrea Swenson. I'm the Residency Program Director and have been in this role since 2014. I was a resident here a while ago and went on to do a fellowship in neuromuscular medicine at the University of Chicago. After I completed my fellowship, there was an opportunity to come back as faculty to the University of Iowa, and I was really excited to do that. I enjoyed my residency here a lot and really liked the idea of getting to work with the UIHC faculty again. When I joined the faculty, I was also offered the position of Associate Program Director. After 6 years in that role, I transitioned into Program Director, and now I'm entering my 12th year in this position. I've really enjoyed building upon an already awesome program, and working alongside our residents has definitely been one of the most rewarding aspects of my career, and I really look forward to seeing what the future of neurology has in store. So I will pass it on to Tracy. I'll have you go next.
Hi, I'm Tracy Cho. I am Vice Chair for Neurology. I moved to Iowa in 2018 when this photo was taken, when I had a lot more hair. My clinical focus is neuroimmunology, and I'm also involved with the overall GME efforts for the University of Iowa. And excited to welcome you and answer any questions that you have. I will pass it on to Jeff.
All right. Hello, everyone. My name is Jeff Kardek. I'm one of the associate program directors for the residency. Like Dr. Swenson, I was a resident here. I left for a couple years after graduating to complete clinical neurophysiology and epilepsy fellowships at the University of Virginia. And then I had the opportunity to return to Iowa to practice both clinical neurophysiology, epilepsy, and get involved in the residency training program. Another opportunity I was given was to help develop an epilepsy fellowship. And I'm excited to say we've had our first fellow enter this year. So I'm one of the associate program directors for epilepsy. And then recently, too, I've taken over the clinical neurophysiology fellowship, too. So a lot of opportunities here to teach, which is one of my main draws for coming back to the University of Iowa. And next, I'll pass it on to Lama.
Thanks. Hi, everyone. My name is Lama, and I'm Jeff Partners in Crime as Associate Program Director for the residency. I'm also one of the Associate Clerkship Directors. So if you're catching on a theme here, we do appreciate a lot of the med ed love, and we try to spread it amongst our trainees. So I'm sitting outside because my husband is currently wrestling with our 1-year-old for her bedtime. So apologies if you hear a lot of like helicopters and lawnmowers and all of that noise. But anyway, I'm originally from Syria. I did my med school there at the University of Damascus and then moved to Iowa for my residency. And I have not left since. So this is basically second home for me now. I did my fellowship in neuroimmunology and neuroinfectious diseases here. I was actually the first fellow. So during my residency, I had the opportunity to work with Dr. Cho to develop the first fellowship from scratch, which was awesome. And straight after fellowship, I took on these couple roles because of my passion about medical education, which we'll talk a little bit about. This is definitely very prominent here, very supported because both Dr. Kardak and I actually were co-residents, and we were part of the CNETP track, which is our clinical neuroeducator track, which puts residents who are interested in having more of a role as medical educators in the future to basically prep them and give them all of the right tools to achieve this later on in their careers. So that aside from that, as I mentioned, I do neuroimmunology and infectious diseases. I very much enjoy what I do because I do a combination of inpatient and outpatient. So lots of nice variety there. And definitely very, very interesting because we live in a catchment area. So we see all sort of things from bread and butter to the most rarest zebras you can think of. And with that, I'll pass it along to Caroline.
Okay, hi everybody. I'm Caroline Martin. I'm the program coordinator for the residency, and I've been with the residency program since 2020 and with the department for I think almost 10 years now. So it's a great place to be. I'm originally from Iowa, just a little bit south of Iowa City, so happy to answer any questions about Iowa and fun things to do as we get into things. I'll hand it over to Alex.
Hey everyone, I'm Alex. I'm one of the chief residents this year. I'm originally from South Dakota, did my medical school at University of South Dakota. Came to Iowa mainly because I was really interested in stroke and it was close to home, and I have not been disappointed. We get plenty of stroke exposure, huge catchment area like we've talked about before. And yeah, the people are is also one of the big reasons. Midwest nice is not just a saying, it's very true. So yeah, I'm happy with everything I've done so far. I'll pass it on to Rachel.
Hey guys, my name's Rachel. I'm the academic chief resident. I'm originally from Reno, Nevada, which is where I did all of my medical school. And coming to Iowa pretty much for the neuroimmunology program was kind of my first exposure to the Midwest. I'm interested in neuroimmunology and neuroinfectious disease, just like Lama, and plan to do fellowship in the coming years.
And I think we have one other chief resident who may be joining us at some point. Jay, hopefully he gets on. We'll check in with him when he does. So yeah, thank you all for coming again. We're really excited to be hosting tonight's open house. And also, I think it's really great that you've all chosen the field of neurology. It's absolutely fascinating, a very dynamic specialty, and changing all the time with new treatments and technology. At the University of Iowa Hospitals and Clinics, University of Iowa Healthcare, when you walk around both the exterior and interior, you really get a sense of how far we have come in medicine. I really like this photo from 1940. This was the hospital's main entrance with this elaborate Gothic tower that stood above everything else at the time. But when we fast forward today, the tower is still there. New name, Boyd Tower, which came about in the 1970s, but you can see it's really now absolutely buried amongst the more modern buildings that surround it. And as time has gone on, there have been more and more buildings that have popped up, both for research and clinical care on our campus. UIHC is an 860 inpatient bed facility, and we also have a children's hospital right next to the main campus, which is 190 beds. But there's more to this picture. Right across the street is the Iowa City VA. The VA has 83 inpatient beds, so on the smaller side, but we still have a very active neurology presence there. So altogether, we're a very large academic center with an extensive catchment area. So we really serve the entire state of Iowa. We also see a number of patients coming from Western Illinois, some from Missouri, others coming from Nebraska. So we're really serving a large area. I also want to give a shout out to two important people in our department. George Richardson, who is our departmental chair. He oversees all that we do from a clinical research and education standpoint and is a fantastic leader and mentor to all of us, both faculty and trainees. And also Dima Fatal. She's a very skilled all-around neurologist who directs our residents' clinical experiences at the VA. And she is a wellness and whole health guru. So she's an excellent resource for our patients and our personal well-being. The overall goal of our program is to provide the best neurological training for our residents that fulfills their career goals. And that can be practicing in the community, working at an academic center, or becoming a clinician scientist. And we do so in a welcoming, supportive environment. We do this by providing comprehensive clinical experiences, high-quality education programs, and empowering both residents and faculty to contribute to and collaborate in advancing our program forward. As the field of neurology has changed, so have we. These changes we have experienced in our program have come about with collaboration between faculty and residents. We really value resident feedback and rely on them to help us move forward. Every month, Caroline, the associate program directors, and I meet with the residents during our house staff meeting. And each month we bring a new agenda to discuss what's going well, what's not going well, what needs to change. And during these meetings, there's been a lot of enhancement to our program that has come out of these collaborations. So our clinical experiences begin with the PGY1 or intern year. This is a combination of rotations through internal medicine, psychiatry, and our surgical and neuroscience ICU. During that first year, we feel it is important to also rotate through neurology, and that gives our residents an opportunity to start building their neurology foundational knowledge, gain exposure to the field, and hang out with and really get to know our neurology team right off the bat. So our interns spend 4 weeks with us on the general neurology inpatient service and 4 weeks doing neurology outpatient clinic. But potentially the best part of that year is the very last rotation. And this is our neurology immersion block. So during this rotation, which is no call, no clinical duties, our PGY1 residents go through an intro to neurology. We focus on emergencies to get them ready for being on neurology call. We do workshops like lumbar puncture, learning basic EEG, EMG, different simulations, team building, and retreats. So prior retreats have included a day at the lake, bowling, and 1 year they went to a really fun trampoline park. So as I mentioned, our program champions for change and values contributions from residents. A big change that got significant input from residents is our clinical PGY2 through PGY4 curriculum. This is based on an X+Y model. This has been in place since 2019, and every year I feel like it has gotten better and better with all the tweaks that we make. So our residents really like it. Every resident has their own continuity of care or COC clinic, and this allows residents to have their own patients and develop rapport with the patients who call that resident their primary neurologist. So the COC clinics used to occur every week despite the rotation a resident is on. And we found this to be quite disruptive to both our inpatient services as well as residents' clinic duties. So we changed it. So the X is a certain number of weeks of a specific rotation. Currently, our PGY2 residents have 3 weeks as their X, and our PGY3 and PGY4 residents have 4 weeks as their X. The Y is 1 week of COC clinics as well as subspecialty clinics, and then also some administrative time for residents to catch up on notes, phone calls, and other things. We have found this to be less disruptive and actually has improved the continuity of our COC clinics. It does provide a predictable schedule for planning weekends off and vacations. And with this schedule, we also found additional benefits specific to the PGY2. So during this year, our residents get quite familiar with treating neuroemergencies and taking care of sick patients. But we also want to give our PGY2s an opportunity to explore the different subspecialties of neurology. And it is essential for them to get as early as possible this exposure. So we have put together theme weeks where the PGY2 resident can focus on a particular subspecialty clinic. So examples would be a week in the neuromuscular clinics or movement or neuro-oncology, neuroimmunology, and so forth. And with this, our residents can see what fellowship opportunities are out there and kind of start exploring that even during that PGY2 year. We've also been able to build in some elective time for the PGY2s to additionally start exploring those interests. Here's an example of the Y or COC week. We do have COC clinics at both the university and the VA, and the residents really appreciate taking care of the two patient populations. Our PGY2 and PGY3 residents spend 5 months on inpatient services, and this includes our stroke team, general neurology team, and inpatient consult team. The PGY4 residents spend about 4 months. And also, as you can see, we have a good amount of subspecialty clinic during our PGY2 year, as well as throughout the other years of residency. For call, we have night float, which is 1 week at a time. That's 6 nights. The PGY2 is the junior on the night float, and either a PGY3 or PGY4 joins them in-house each night. Our residents do really like the 2-person call team, which provides a lot of support for the junior resident, and the senior resident gets more autonomy. Of course, we have multiple faculty members on call every night and are readily accessible for questions and support for our residents. We are excited to offer many different types of electives for our residents. I've listed some of the more common choices. Our residents really enjoy the advanced neuroanatomy elective and the ability to collaborate with a faculty member to get creative and develop their own elective. We have a strong partnership with neurologists throughout the state of Iowa, and through that, we have been able to develop a community elective where a resident can rotate with a neurologist outside of the university and experience what a community practice looks like. Here at Iowa, we provide our residents with a well-rounded clinical experience, exceptional didactics, and a multitude of research opportunities. We are the only academic medical center in the state, so we have a diverse patient population with great cases. Not only the bread and butter of neurology, but also plenty of rare diseases. Our faculty represent multiple neurology subspecialties, so residents get exposure to all aspects of neurology. And one thing we're really focusing on is making our clinical practices as efficient as possible. We utilize AI-powered note generation for more efficient practice and allowing our trainees and faculty to focus less on note documentation and more on what really matters, such as spending more time with our patients and less at our computers. And I've really appreciated having this technology available because it has definitely made an impact on my clinical practice. We have a didactic curriculum that residents participate in every day at noon. This features pretty much all of our clinical and research neurology faculty. In addition, we have a monthly concentrated didactic session. This is a 2-hour session that usually happens on the second Thursday of the month. We provide lunch and protect the time for residents with faculty, fellow, and APP coverage. These sessions focus on high-yield clinical neurology topics, and we also include some board review. A few of the past year's sessions have included approach to neuropathy, approach to muscle disease. We had hosted a neuroimmunology extravaganza and approach to headache and migraines. These sessions have been very informative and residents have been rating them highly. Additionally, we host weekly grand rounds with internal and external speakers, and throughout the week, there are additional conferences that residents can attend, and these include things like neuro-oncology conferences, tumor board, muscle pathology, brain cutting, neuroanatomy labs, so a lot of different things that residents can do. For the entirety of our didactic curriculum, we utilize a lot of resident feedback as well as in-service exam scores to tailor our didactic sessions to our program's needs. For research opportunities, there are many mentors to guide residents' scholarly projects. We are a site for StrokeNet and NeuroNext, which allows us to be a site for multiple clinical trials. For the stroke trials in particular, residents are definitely an important part of this process. Oftentimes, the residents will be seeing the patients while in the while in the emergency room and helping our team make decisions on whether these patients will be appropriate for acute stroke trials. And residents can also jump in on basic research, educational research, as well as QI, and there's definitely faculty support in all of those. We have creatively designed tracks within our program to enhance residents' educational experience. The Clinical Neuroeducator Training Program, or CNETP, provides training in the foundations of medical education as well as educational opportunities with learners. So residents in this track acquire skills to become effective educators, develop and implement scholarly projects with goals of becoming future education leaders. As was mentioned earlier, we are really honored to have two of our CNETP graduates, Drs. Abdel Wahed and Karduk, on faculty and in the roles of APDs. Also, some really cool things about our residents is that they are excellent teachers. They have been awarded multiple teaching awards for medical students. We also have a formal tutoring program. Residents tutor students on the neurology clerkship who are looking for additional support, whether it is neuroanatomy or clinical neurology. Our residents have been really helpful in that area, and there is a stipend for the tutoring program. The Clinical Neuroscientist Training Program, or CNSTP, is designed for trainees interested in pursuing a career in academic neurology who have already demonstrated proficiency in biomedical or clinical research. This unique program is supported by an NIH grant, and we provide close mentorship and flexible scheduling to balance residents' research and educational goals. Two of our faculty, Drs. Aldridge and Zong, graduated from our CNSTP and have their own labs and have secured a lot of competitive independent funding. So it's been very cool to see their careers blossom. So we are committed to creating a supportive environment for everyone on our team. Our wellness team has compiled resources for mental and physical health, including facilitating resident access to primary care providers. Our GME has hired a psychologist who works solely with residents and fellows and is really an excellent resource for well-being. We are continuing to develop strategies to reduce burnout, finding ways to decompress and to discuss challenging and difficult cases with each other and help each other achieve work-life balance. We provide enhanced mentoring both at the faculty and peer level and have frequent check-ins from leadership. I meet with residents individually throughout the year to see how things are going. And each resident is assigned a neurology faculty mentor before starting PGY1. And then also our PGY1s are assigned one of the internal medicine APDs as a mentor during their intern year to have that additional faculty support. We want to connect with our community and do this by bringing awareness of neurological disorders and providing shadowing opportunities for undergrad students to enhance early interest in neurology and neuroscience. And our faculty and residents staff the neurology clinic at the University of Iowa Mobile Clinic, which is a largely student-run clinic for uninsured populations throughout Iowa. So that is the end of the presentation, and I will turn it over to our chiefs, who will be jumping in here to discuss life as a resident in Iowa City.
And Jay is on now. Jay, if you would do a quick intro so everyone can meet you.
Still muted, Jay.
Okay. I think that's enough with the technical difficulties tonight. My name is Jay Lefkowitz. Hi, everybody. I'm from the Massachusetts area. I'm another one of the chief residents. I'm in charge of scheduling this year. And look forward to answering any of your questions today.
So yeah, let's hear from our chiefs about life as a resident in Iowa City.
Yeah, I can start us off. I think life as a resident kind of depends on the year and also like the rotations that we're on. So overall, I think for most of the year, all of the years, there's plenty of time to have a life outside of medicine. PGY1 especially can get kind of long because each rotation is a little bit like a month long, and most of them are inpatient internal medicine rotations. But even despite that, there's plenty of outpatient rotations intermixed within those to have a life. I had an apartment right off the bat, like 1,000 square feet. I had plenty of time to go to the gym, meet people, hang out with co-residents, and all those things. So yeah, I think there's a lot of balance that can be had at our program for both life in the hospital and life outside the hospital, as well. I can pass along to my co-chiefs if they also want to add to this a little bit more.
I can say a little bit about something of resident life that's at Iowa Next. So yeah, I agree with Alex. There's a pretty good balance here. I think that, overall, I would emphasize that it's a collegial environment. And being in other residency programs before this, I'll say that the residents here really genuinely help each other, and we enjoy working together. So I wanted to emphasize that point. And Iowa City, it's this is my first time in the Midwest area, but for a smaller city, it does have a bit of a cosmopolitan feel for it. There's nothing as far as culture here that you wouldn't see in some of the bigger cities. And one of the good things is that it doesn't come with the price tag of the bigger cities. So the cost of living is much better. You can easily, if you're upward, you can own a home in residency. Even in today's climate, you can rent affordably. And one of the things that I was very important to me, being in a bigger city before, is having a short commute, and you can have a real short commute here. You can live close to the hospital. You can be in and out in 15 minutes.
All right. And I'll just kind of add to what my two co-chiefs have said. So I agree with everything they've said so far. Like Jay, I'm also from a bigger city. And so I was a little bit apprehensive about coming to the Midwest. But, as residency's gone on and I've learned more about this, city, and the university and the history behind it, it's such a great place to live. There's so much to do. And like Alex mentioned, just the bond and like the friendship between the residents is really important because on one hand it's kind of like you're going to work with your friends, and on the other hand, you can still hang out outside of work. And we actually, our class has been doing like at least monthly meetups since PGY 1 year. And I don't think we've ever missed one actually. So yeah, it's a very collegial environment. I would agree.
And there's a question about a particular neighborhood or apartment complex that's popular among residents. Someone wanted to know where residents live.
So I will say it's also a college town, so there's a lot of affordable housing for the undergrads as well as the residents and med students. I know a lot of people that live within walking distance of the hospital. Granted, it's going to be probably a little bit more expensive to live there. I have about a 5-minute commute from the hospital, and my place is it's in a very nice neighborhood, and so there's apartment complexes kind of all over the place. There's another area called IRL, which has like a lot of the newer restaurants and like shopping districts, and there's apartments over there that a lot of people live in as well.
So we do have some questions from that were submitted to us earlier that we can go through. One of the questions was, what career paths do residents typically follow after graduation, such as fellowships, academic roles, or private practice? And it is quite a variety. Some years it seems like there's one type of fellowship that seems more popular than others, and then the next year it's totally different. I will say that a lot of our residents do stay here for fellowship, which is super fun because we like our residents so much, and working with them as a fellow gives us more time with the resident, and it's fun to see them transition into that role. We have residents who've gone into practice right after residency training, others who've gone into more research fellowships to try to develop a clinician scientist career. So it's really been quite variable. We've had residents go into fellowships like clinical neurophysiology, neuromuscular epilepsy, neuroimmunology, movement disorders, neurocritical care, stroke, neurointerventional. So a lot of different interests, and it's really cool to work with residents here during their 4 years, all working together and building their individual interests. And then when they graduate, it's a very diverse career choices. So I really appreciate getting to work with residents with so many different interests in what their career looks like after graduation. Okay. I can kind of go through some of these questions from before. Lama, one of the questions that came in was, how active is the neurology residency program when it comes to research, and are the attendings supportive of new ideas?
All of the above, yes. So I would say 100% research is extremely strong here, and it is, I love the fact that it is available for both seasoned researchers, so students who have had like humongous path into research during their undergrad, medical school, etc., or have dual degrees, etc., and also for novice students slash residents who, like myself, I had basically zero exposure during my medical school, some exposure as I started rotating in the US, and then I wanted to start somewhere but had no idea where, and then you will get all the mentorship that you would like. So I would say at any level you are in your path, if you have any interest in your research, you will definitely hook you up with a mentor. They will find you at where you are at, what are your goals, and then they'll help support you to achieve what you want to achieve out of it. So I would say 100% mentorship here is probably one of our strongest as well, both clinically from a medical education perspective and from a research perspective. So in terms of examples, and I'm going to be pulling both from my experience as a resident myself and now currently as a faculty and a mentor. But we have coming up now a symposium, for like a poster symposium for our residents, where they can submit abstracts to our leadership, and then they can create posters out of it, and that will go into their CV. And potentially we were gonna potentially help them to make it to a national level at any of the conferences like AN, etc. So we will basically do like a kind of a not a competition, but basically like do like give them feedback on the posters and potentially give an award for the best poster based on specific criteria. But that discussion that would happen during that poster session, I remember I had it when I was a resident. It was extremely valuable for my experience as a novice poster creator, and help later on once this become a very like kind of normal and everyday thing that we do now as a faculty and to help mentor other residents. So definitely I remember that experience from my first year as a resident, and I remember how much I valued it, and I'm very happy that we continue on this tradition to help our upcoming residents. Other examples when I was a resident, so Tracy was, well, still is my mentor, and he helped me kind of figure out how to write a review as well from for an invited to like seminars in neurology manuscript. And that was a very, very enlightening experience to me. It showed me how much I had no clue what's going on and how patient he was to help me like write through a big review that basically helped me become an expert in this very specific topic. And just last year, Rachel and I had a nice first author manuscript for her and practical neurology about CNS infections. So I can let her speak a little bit about that. So there are definitely very varied experiences in terms of exposure to research. Ideas are always welcome. And most importantly, you'll get feedback about those ideas and how achievable they are and what is the way about achieving them or fine-tuning them so they can become achievable. So yes, 100% very well supported. Now, Rachel, do you want to speak a little bit about your experience?
Sure. So my experience is basically the exact same as Lamar's. I had done, some research in undergrad, but I wasn't super into it in medical school. And then coming into residency, I didn't really have any particular specific research interest. And then this kind of opportunity came up, and I was apprehensive because, like Lamar said, you don't know what you don't know until you actually do it. But it was it was it was a great experience working with a close mentor and figuring out kind of how to get into that world. And so, I always tell like my junior residents, like if I could have done it, you can do it too. So
Yeah, and I'm only speaking mainly to these like kind of more clinical based scholarship because I myself I'm not like a physician scientist, but we do, if you are someone who would be interested in more like NIH level applying for grants, etc., then we have the CNSCP program, which Dr. Swenson has alluded to a little bit, and a lot like very like great details is presented on the website if you'd like to explore that further.
Right. Jeff, there was a question about the most pressing neurological needs of Iowa's patient population in terms of demographics, access, and disease burden. How is the program working to address those needs?
Sure, yes. So I wouldn't say it's necessarily unique to Iowa, but I'd say we're in the minority of states that we are the academic health system for the state. And we're geographically located in a unique position for that, where so Iowa City is on the far eastern side of Iowa. And so there's a vast part of the state that's having to travel, hours to come to the university. And we really see it as our job to provide good healthcare to all of Iowa. In addition to that, we're a respected group by our surrounding states, and so we often serve as a second referral for states like Illinois, Wisconsin, Minnesota, Nebraska, Missouri. And so balancing all of the needs of the state does present some opportunities and some challenges. So as far as the demographics go, I think a need for our state where we're stepping in and intervening would be caring for those who are underinsured or uninsured. So a way our department is doing that is we've partnered with the University of Iowa Mobile Clinic to offer opportunities throughout not only Iowa City, but the surrounding communities too, where we'll go to community locations and provide free healthcare, no insurance questions asked. The team for that is usually composed of a medical student and a resident, giving the resident autonomy, kind of supervising medical students making decisions together. And there's also a staff neurology attending who participates in the clinics too, sometimes on site, sometimes remotely, to offer care and decide, what can be done in a setting of more limited resources. Is this something that can be managed or locally, or is this something we really need to facilitate more urgent access to a place like the University of Iowa? So residents and students really enjoy this opportunity to kind of give back to the community and work with others who are passionate about community involvement. As far as access goes, I kind of alluded to this earlier. Our geographic position is unique, and Iowa is a largely rural state. So we have a couple big cities, but then these large geographic regions of more rural communities. We're spoiled in the Iowa City area. I think our healthcare system probably employs at least half of the neurologists in the state. And so we have a kind of abundance of resources located on the eastern side. And so the challenge becomes, how can we provide high quality care throughout the state of Iowa, including rural access hospital, critical access hospitals located in more rural situations. Does the patient need to travel 3.5 hours to the university to get the care that they need if they're admitted, or is there a way we can provide our expertise locally? So that's something our department is working on right now. One of our stroke faculty is working on a teleneurology network to plug in the University of Iowa to more local hospitals, so that way we can care for the patient close to their family and their local community. So I'm really excited for that. It'll be great to see it implemented, because for many of our patients, it's hard if you're relying on other people for transportation because you have cognitive difficulties or you have epilepsy, to get the care as you need it. And then disease burden. So I'd say an area we're working on making improvements for disease burden is particularly with our critical care population. So right now, the setup of our ICUs is we have co-management in a unit called the Surgical and Neurologic Intensive Care Unit. So there's a critical care team that's separate from the neurology team, and the critical care team will kind of act as primary for most organ systems. If the patient has an infection, they'll treat that. If they're diabetic, they'll do the insulin management, vent settings. And then the neurology team will take primary on most issues that are thought to primarily be neurologic. So they'll choose anti-seizure medicines, they'll help manage increased intracranial pressures, they'll provide blood pressure goals for a patient after stroke. So one thing we would like to do is to kind of have one team ownership and to have a dedicated neuro. And I should mention too that the two teams. So the neurology team is staffed by a neurology attending. The ICU team is usually staffed by like an anesthesiology or surgery attending. So one of the things we're hoping to do on this end is to combine it and have kind of one team primary for these patients. Steps we've been taking towards this would be, we just hired our third neurocritical care attending, who started a couple months ago, which has been really exciting. And then the healthcare system overall is moving towards planning for a new inpatient tower that's going to expand our access to beds and resources. And so we've been putting in a plug for a dedicated neuro ICU where we'd be able to kind of have our own resources, own equipment set up for the care of patients with primary neurologic concerns. So both with increased space and increased neurocritical care attendings, we're hoping to take on, I think, a more traditional primary closed neurocritical care unit.
One thing I just want to mention, talking about access and the catchment areas and the patients that we're seeing, because we're such a large medical center, a lot of our departments and divisions have very specialized clinics within them. So I can speak to our neuromuscular division. We have clinics that are very unique and not found at a lot of other centers. For example, our CMT or hereditary neuropathy clinic draws in patients not only from Iowa, but from across the country, as well as some patients coming from outside of the country. So it's really serving quite an array of patients coming from all over. We also have a myotonic dystrophy clinic, which you don't find at a lot of centers, and we see patients coming from all over just for that specific care. So it is a really great opportunity for residents to see patients with those disorders, but also being managed by a team that is so specialized. Right. So Alex, a question came up about leadership responding to resident feedback and how that goes.
Yeah, of course. So I'm the administrative chief, so I'm kind of the intermediary between the leadership and also the residents. It's my role at this point. Before this, I was the stroke liaison. Just because the stroke team is such a big part of residency education, and it's a busy service for any residency that you go to. So a lot of the feedback that at least I saw during my tenure as the liaison and now administrative chief has a lot to do with the stroke service. And one thing that I heard years ago is that the primary stroke service was primarily run by residents. And at that point, it was incredibly busy, like 15 patients per resident and around that same amount of patients. A lot of feedback came from that, from the residents, and mainly that the workload was just too much for a resident to be able to handle at that point. And the feedback that we gave was, can we do something about this? And the leadership responded really quickly during that time and hired nurse practitioners to be able to offload the residents during that time. And that happened almost immediately, I would say. Um, and that was one of the big changes that happened, at least in the past 5, 10 years from our side that I was able to see. So yeah, that was one thing where feedback happened, leadership responded immediately and improved resident lives. And from what I've seen so far now, um, recently the stroke service also ballooned out just because it can get really busy during holiday seasons too, because a lot of people with strokes will have disability, they need to go to a rehab facility afterward. And during the holiday season, that can kind of get backloaded. So more feedback from the residents was that this is getting difficult. Can we do something with more nurse practitioners? And another nurse practitioner got hired almost immediately right afterward too. Um, so that just gives you a sense of how quickly and how seriously that resident concerns are taken for that. And being able to hire nurse practitioners is no small feat either. So, and the ability to do that was, yeah, really a good thing. So yeah, those are kind of the bigger things that I've seen in the past years. Yeah.
Um, okay. So Tracy, a question about during training, do residents get more exposure to theoretical knowledge or hands-on clinical experience? Would you describe the patient population as diverse or more consistent in terms of the types of cases seen? I guess those are kind of two different questions.
Sure. I will take on the theoretical versus hands-on. Residency and doctoring in general cannot happen without hands-on, and we have lots and lots of patient-based learning that goes on. We do recognize there a given resident in a given time period may not see all the range of pathologies that are on the board exam. And so there's also different times where your brain needs to consolidate, slow down, and be able to ask questions outside the stressors of the inpatient or clinic flow. So we have robust didactic curriculum as well. But the meat and heart of, for those vegetarians, the sustenance of the program is the patient-based teaching. And that's where the magic happens. When you get an experienced neurologist with a patient with an unusual exam finding, or a tough discussion that needs to happen, or managing how to explain things for a patient and their family while also teaching a first-year medical student and a senior resident. That is all where I think where our program is particularly strong because of the emphasis on patient-based teaching. That happens to also be my teaching philosophy is no matter how much you hear about it in a lecture or read about it, it does not stick the same way as it does when you meet a person dealing with the disease or syndrome that you're talking about. We have taken to Alex's question and response about feedback. We have kind of evolved how our formal didactic curriculum looks over the years in response to resident feedback, including having monthly protected didactic time off the pager for the most part. The service is being covered by the faculty or APPs or others. And that has gone very well. But we also have robust daily noontime conferences and discussions. In terms of the patient population, as multiple others have previously mentioned, because of the catchment area, we have a huge range of diseases and patient populations in terms of age, urban versus rural, different ethnic demographics, socioeconomic, but also those zebra diseases that happen 1 in a million. We see several times a year, such as NMDA receptor encephalitis, Creutzfeldt-Jakob disease, CNS vasculitis, neurosarcoidosis. We see that one actually multiple times a year. So in addition to that, there's a ton of bread and butter opportunities with strokes, neuropathies, dementias, epilepsies, etc. So it is a great breadth and depth of disease pathologies and patient types. I think there was a question about the VA interplay there, and yes, there is more bread and butter at the VA in addition, and I think some of the residents like that and enjoy their continuity of care clinic there. You get a different flavor at the VA for that in particular than you do at the university.
All right. Jay, can the residents, I guess I'm opening up to Jay and all the residents, can you speak about the mentorship culture, especially in helping residents explore career paths within neurology?
Yeah, for sure. So first I'll talk about the mentorship, and then I'll talk about exploring career paths to break it down. So I would describe this as at Iowa, essentially an intentional mentorship culture. So if you come to Iowa, you are going to be mentored, and from even early on, you are going to mentor as you progress. Early on, there's formal pairing, as Dr. Swenson mentioned earlier. You get paired with a faculty member right from the beginning. And you're going to have check-ins with that faculty member. And there's also, as you develop and start to get interests in different subspecialties of neurology, if you will, There's also going to be an organic membership or mentorship that happens as you work with those subspecialty faculty more and more. And I would say that, all of the faculty here, everybody I've met at least, everybody is very approachable, and not just approachable, but they are invested. Whether you're like myself, exploring, stroke, neurocritical care, things like this. There's also, neuroimmunology or research. I think that if you develop an interest and you pair up with faculty, they are there for you, and they can guide you well. I'll also say that this is a very I'll say kind of protected program, because you're never alone whenever you're on call. Even from the beginning, there's always a senior resident there, and I think Dr. Swenson talked a little bit earlier that there are also multiple faculty on, just a phone call away, even overnight. But I think on those call days, where you kind of have the service by yourself with maybe a senior resident, or vice versa when you are the senior resident. I think that's where a lot of the learning happens, and you can start to realize what you know, and kind of gets mentoring on the fly from a senior resident. And then so you'll be calling in to faculty overnight, to check your plans for some of those patients as well. So, like I said, it's I describe it as an intentional mentorship culture at Iowa. And as far as career path like exploration, the early on we from your PGY2, you start rotating through clinics. Every so many weeks you have your clinic week, and you have your own clinic, of course, which can be a variety of different patients. But the weeks kind of have a theme, whether it be neuromuscular, whether it be epilepsy, whether it be stroke. So you keep hitting these specialties at kind of spaced intervals. So you get some taste of it, right away. But you also have electives that start. You get more electives as you go, as you progress from PGY2 to PGY3 to 4. But you also have electives early on too, where you can kind of spend more dedicated time in a specific specialty. And I think we've talked a little bit about research as well, if that's something that you're interested in. There's plenty of mentorship opportunities for research, and you're at a major academic institute here. So whether it be basic science, clinical outcomes, essentially, it's wide open. You'll find somebody to work with. Maybe I'll turn it over to somebody else to say something.
No, thanks. I do think mentorship is extremely important, and that's one thing that I want to make sure we have in place before our PGY1s start with us. I do ask them if there's a particular faculty member they'd like to be paired up with, or if there's a subspecialty, or if they were not sure. I will kind of see what I think would be a good fit. But we do have more faculty members interested in being a mentor than residents available for them to be their mentor. So I have a list of faculty who did not get assigned a mentor this year, but they really want one in the future. So I will make sure to assign them. But they really, really like that role in mentoring residents and helping them decide on their career paths and guiding them. And our faculty is very well connected with different neurologists throughout the country and world. So I think we're a great source for residents interested in fellowships in various places and getting them connected with the people who can also help them in the field. All right, so another question, and this was for Rachel, but I'll open it up to everybody as well. What do you think draws residents and faculty to choose this program?
All right. So I think that, the fact that everyone kind of keeps coming back is a real testament to the quality of training that you get here, and the level of, mentorship and the opportunities that you can expand, your personal and your professional growth so much. Um, that's one aspect of things, but as I saw Lama type in the chat box, the people are really the biggest thing, I think. I never thought that I would say that I'd be sad to be leaving residency, but as my fourth year is coming on and I'm thinking about leaving all these wonderful people, I'm actually very sad. It's just such a wonderful place to work. We have a lot of support staff. We get along well with our colleagues in other specialties, and a lot of us are, friends. So it's really just a wonderful place to work and to learn. And like I said, I'll be very sad to leave this place.
We are always sad to see our residents go as well, but also very proud of them for what they've accomplished and what they will accomplish in the future. But what I really love about working here is the people, residents, faculty, fellows, our students, people like Caroline and everyone else we work with in our department. They are just great people and very focused on what we're doing here and focused on our goals and wanting to make sure that they're doing the best they can, getting the most out of what we do and really bringing everybody with us together. So I really, really appreciate my colleagues very much and enjoy working with them every day.
And just to echo what everyone said, I already tapped it in the chat, but I'll just say it out loud for everyone who missed my answer. But yeah, you can find great science wherever you go, but you're not going to find these folks anywhere else. So definitely go where it feels like family, because those people will have your back and you'll have theirs. And honestly, there's nothing like it. Like I'm still in touch with my co-residents up until now, and some of them are my colleagues right now, which is awesome. So yeah, I would say definitely the people, the family that you create here during residency and later on. And it's just a joy to now get to work with the residents every day and learn from them, because truly it is like the best collegiate environment you can hope for.
And I'll add to that a little bit too, because faculty are great, co-residents are great. Those relationships are awesome. And a lot of residency programs as applicants will say the people are awesome. And for Iowa, it's really true. I will also miss leaving residency, but not even just like the co-residents, faculty, and everyone there, but even nursing staff and the support staff. And like I'm friends with the radiology tech that I see every night because we always go to the CT scanner for patients. So yeah, it's not even just those. It's a great culture all around. Like I can't say I've ever heard the word toxic in Iowa in the same sentence.
So there was a question, and I think this will go to Jeff. Will the residents still be able to read their own standard and continuous EEGs as a part of training?
Yeah, that's a great question. I think it's related to another one, is what kind of like procedures do residents get experience with throughout their residency. So I'll kind of take both of those. We do a couple thousand kind of enterprise-wide EEGs per year. Our program for fellowship training is on the smaller side, so we have one clinical neurophysiology and one epilepsy spot per year. And the epilepsy one is split between adult and peds. And so there are a lot of opportunities for residents who are interested in getting exposure to EEG to read their own studies. We start during the PGY 2-year mentoring residents in how to read an EEG through a 1-week elective through EEG, going over what is normal, kind of fundamentals of EEG, what are all these numbers and letters mean, what does squiggly lines mean. And then residents throughout their PGY 2-year, both on call and then on the consult service, will interact frequently with the clinical neurophysiologist who's always on call with you. So during the day on the consult team, we have scheduled EEG rounds at 2 o'clock every day, where the team can come down and we'll point out interesting EEG findings for the patients that they're following. So that way we can have a touch base on, one, how is EEG doing since that morning read that you got? And then showing interesting findings to help residents be able to identify them on their own. PGY 3-year, residents will start to rotate in the epilepsy monitoring unit. And so this is an opportunity to work one-on-one with an epileptologist reviewing EEGs. Most of us will ask the resident who's on to kind of review one EEG from the patient they admitted the day before and go over and try and mark findings on their own. We always do kind of a read behind the scenes. And then we have residents kind of point out their findings, and we base teaching off of that. And then if there are any findings we identified that the resident didn't, we use that as an opportunity to kind of show them and give some feedback. So here's some other things to look for or consider when you're reviewing the study. A very popular elective now too is coming back to the EEG lab during PGY 3 or PGY 4 for critical care EEG elective. And so this is an opportunity to get more experience once you built those foundations with like rhythmic and periodic patterns on an EEG. How does status epilepticus look? What is this ictal interictal continuum? If you haven't heard of that now, I promise you will during residency. So it's an opportunity, very popular amongst residents. We also look at, how can you become more efficient with EEG readings, whether it's utilizing quantitative EEG or different features within the software itself. So I'd say there's a lot of, and I'll open up to the current residents too. I think there are a lot of opportunities to review EEGs if that's an interest. And we definitely have residents, including in this group right here, who are very good at reading EEGs and feel confident by the time that they're leaving residency. So EEG is something I think residents get a lot of exposure to. Other procedures that we offer exposure to, EMG, similar to EEG, we get early introduction to EMG during the PGY 2-year, a dedicated 1-week rotation, working one-on-one with a neuromuscular neurophysiologist trained in EMG. And opportunities exist to do continued electives throughout PGY 3 and PGY 4-year. We have had residents in the past take advantage of the flexible elective scheduling and hit the 200 EMGs required to be able to become certified in EMG upon graduation from residency. So that's another procedure. One of the more popular ones I'd say residents have been doing too is learning how to do Botox injections for migraines. And so this has been really exciting for me. I'm at this point older than I care to admit and graduated a long time ago. But back when I was training, we did not have any headache specialists here. And so it was hard to get experience or exposure to different headache procedures. That's been a huge area of growth for us over these last couple of years. And now we have two faculty and I think 3 APPs who are all doing Botox for migraines. So that's been really exciting. Residents have a really good experience learning how to do Botox injection for migraines. Some other procedures I'm not going to cover in quite as big detail, but other procedures residents will get experience with. Those interested in doing Botox for spasticity, it is done in our movement clinic, and doing a movement elective will get some experience with that. And then new as of last week, we just put forward an intraoperative monitoring elective. So for those interested in kind of the continuous monitoring of all the other neurophysiology tests in the setting of an OR, it's an opportunity we have. And residents seem pretty excited about it. I think I've already had 3 people sign up for it.
Yeah, that's great. And I do have to say I'm always very impressed with how well our residents do with reading EEGs. Great job, guys. But depending on what residents' interests are, we have the ability to work with them and their schedule to get more procedures like EEG, EMG, Botox, whatever they're interested in. We definitely have the ability to set that up for them.
Yeah, I'll say it as a side too, having gone to somewhere with a larger fellowship, I got to interact with residents who are graduates of programs all across the country. And one thing that struck me is I feel like Iowa has a really good balance between fellow and resident support. So that way there's no competition between the two. Both can get plenty of exposure and experience to procedures if they wish.
I don't see that we have any other open questions. I guess one just came through, an opportunity to take part in the programming and follow-up of a patient with DBS. I will let the residents take that question.
Sure. So we have a lot of movement disorder attendings, and you'll rotate with them in clinic, when either on your elective or on your designated clinic weeks. We definitely see a lot of people with DBS. Regarding like programming it independently, I don't think that would be something we would do at the resident level. That's probably more like fellow level. But definitely like they'll have you hold the iPad and they'll say, okay, turn it up to this and see what happens. Move this around, see what happens. And then they'll ask you, like what do you want to do? Do you want to, and then obviously like you run your decision past them first. But so yeah, you definitely do get to participate and you get to do the exam, like at the different settings and say like, okay, do they have more bradykinesia at this level or do they have, tremors at this level? And so there's definitely opportunity to learn it very, very well.
So this is a really great question. What are the food options like while on call? Who wants to tackle that one?
I can talk about this one. I was just on call, so I very recent in my mind. Overnight they have it's kind of like a mini cafeteria that they have that's open all hours that you can go to at any point. They have hot foods, kind of depends on the night, but they had like salmon one night. They had like a potato bowl for like KFC style the other night. They've got salads, they've got like sushi if you want that. So there's a lot of options overnight too. During the day, I forget how many cafeterias we have, like four or five. Um, there's one called Atrium, which is like the fancier cafeteria, a little bit more expensive, but it's like restaurant style food. And then Fountain Dining, which is more like a typical hospital cafeteria that they'll have a hot meal, depends on the day, usually like a walking taco or like a baked potato bar or a salad bowl, anything like that. Burgers, fries, sandwich station, sodas, that kind of thing. But there's plenty of food options like all around the hospital pretty much all the time. And then likewise, we have like a microwave in our resident area, which is a really nice area. And then like a refrigerator. So if you want to take meals from home, we've got a space right next to where we work that we can store food to. So no shortage of food by any means where we are.
What about the VA? They have food options there, right?
During the day, yes, they've got the cafeteria that they have. Overnight, less so. The only time we'll be overnight at the VA is during first year. Um, Still limited. They've got vending machines. They really say that you should take food from home during those times. They call it.
Do they have a Starbucks over there?
Not anymore.
Oh, darn.
Oh,
Okay.
just kidding.
Yeah. Another thing, like at the VA, I've definitely like door dashed food to the VA or like had pizza delivered and it was fine. There were no problems with that. So
Gotta say, salmon overnight is definitely much better than the most reliable thing which we had when I was a resident, which is the cheese balls. So I'm glad you guys get salmon overnight now.
I'd say cheese balls is like 95% of the time now.
always reliable. It has your
Right.
back. And I would say this, you guys get call money as well. So do you want to mention that, Alex?
Yeah, of course. Caroline can say the amounts a little bit better than I can, but we do get a refresher every July that we have a specific amount that we're able to use at the hospital, and this works in any cafeteria, fancy atrium dining or otherwise. And that can usually last you the whole year, depending on, how often you use it. But if you did like one meal per day, that would probably last you the whole time.
Yeah,
And
you
please,
get more the more you're in-house overnight. So your PGY 2 year is the year you get the most call money. And I believe you actually get call money from the VA too for your intern year. And I've heard that that does not expire. So I know there are residents who will use that for like multiple years.
Yeah, I'm at the VA right now, and I'm just now in the fourth year, winding down to the last bit of the dollars on the VA call money. So they give you a little bit, or they give you quite a bit at the beginning, but it doesn't ever expire. So it, depending on how often you're at the VA, it could take till the end of the fourth year to exhaust it.
There's also a variety of coffee shops within the hospital. There's one called the Bread Garden and another one at the other end of the hospital called Java House. And I think people might be sort of partial to one or the other. And then on Thursdays, there's food trucks that come to one of the outside courts near the medical school. Um, I have never actually attended these, but I've walked past them and they look like a lot of fun, like a lot of good food.
There's often live music as well, and a real big variety of food, ethnic and otherwise.
That might be a good question to end on. Food, it's always a great topic, and there are a lot of great restaurants in Iowa City. I'm always excited to go out to them. There's also a lot of great restaurants in surrounding communities. They have a lot of farm to table and different wineries and breweries that have good food as well. So it's a very fun culinary city, in my opinion. Well, thank you to everyone for joining us tonight. And thank you, panelists. It's always great to see you and chat with you. But we will have a recording of tonight's event on our website. So I encourage you to check that out if you want to review it. And also, our website has a lot of great information about our program. And if other questions come up, feel free to reach out to us anytime. All right.
Good luck to everyone.
Thank you, guys. Take care.
Good luck. Thank you for listening.
thank you.